राव सर कहाँ है?
You are seen somewhere.
There is messaged. वेटिंग रूम ऑफ कर दें क्या? सर मैं कर दे रहा हूँ सर एंटर तो वैसे। One has joined Zoom user. उसको एडमिट नहीं कर रहे हैं सर। अभी अल्टीमेटली वी हैव टू स्विच ऑफ म्यूजिक। इतने लोग आ जाते हैं ना, वी कैन नॉट। लेट मी डू द सेटिंग। होस्ट टूल्स है हमारे पास, ठीक है। वेटिंग रूम, शेयर स्क्रीन, जो भी वेटिंग रूम ऑफ कर दो। ठीक है सर, क्योंकि करनी वी कैन नॉट मैनेज सो मच क्राउड। जो आएगा निपट लेंगे, नॉट एन इशू। सो वी हैव द पैनल नाउ। इट इज ऑलरेडी 8 o'clock हो गया है।
Yes, sir.
Can start.
Yes, sir. Ready, sir.
Dr.
We can
Kalpesh
start
is
now.
here. Everyone is here. Dr. Anup Rawal is here.
पैनल को होस्ट बना लिया है?
Yes, sir.
ओके, वी स्टार्ट नाउ।
Let us
Yes,
start.
sir. I'm ready.
Share the slides, please.
सीमा ठाकुर,
Please make Dr. Seema as co-host. You will be able to unmute then. Ma'am, welcome.
Yeah.
Welcome, ma'am.
Thank you.
Shreya, do we have the slides?
I think Dr. Vishal has the slide of intro.
Vishal bhai, please share the slides. We can start now. Vishal, do you have slides? Are you sharing or Shreya is sharing?
Unmute yourself, Dr. Vishal.
You are muted, Dr. Vishal.
No, I could unmute myself, sir. I got logged out and I could unmute. So I had to join in from the laptop.
We are seeing Ram or Sham on the screen, two Vishals together.
Do you have the slides?
I don't have the slides. I don't have. आपको एक बार वो लेना पड़ेगा. Was there two Vishal? Oh, okay. This is very odd. Okay. I can't see two. I don't have the slides. एक मिनट.
Are the slides visible now?
Yes, sir. Slide is visible.
So I'm sharing it. Yeah. So my warm welcome to all of you. This is the 226th edition. Today we'll be talking about a very basic, very important topic. Often we miss it. So we'll talk about basic of genetics, what a psychiatrist should know, and how we can use it in our practice, improve ourselves. The session will be recorded and put on YouTube. The recording is on, Shobit? Yeah, the recording is on. Everyone will be on the mute mode. Questions are invited in the chat box, which will be taken up to the presenter. So these are the simple rules. Next, handing over the session to Professor Dr. Tufan Pati sir. He is the chairman of this program. Sir, over to you to take it up further.
Thank you, Dr. Ali. Should proceed as fast as possible. I welcome and highly appreciate our vibrant moderators, Dr. Vishal Chabra, Dr. Aleem Siddiqui, Dr. Amrit Patadusi, and Dr. Shobit Garg. Today, our chairperson is Dr. Kalpesh P. Chandrani, Assistant Professor, Department of Psychiatry, PDU Government Medical College and Hospital, Rajkot. MBBS from PDU Government Medical College, Rajkot. MD from MP Shah Medical College, Jamnagar. Full-time Psychiatrist District Mental Health Program in Amreli from 2006 to 2007. Assistant Professor at Department of Psychiatry, PDU Government Medical College, Rajkot. And then Associate Professor in the same department. And till date he's working. He's a PG teacher since 2013. His publications involve analysis of adverse drug reactions of atypical antipsychotic drugs in psychiatry, quality of life in caregivers of patients with bipolar mood disorder with current manic episode and its correlation with severity of illness, quality of life in caregivers of patients with schizophrenia and its correlation with severity of illness, prevalence and pattern of psychiatric comorbidity in patients with epilepsy, hypnotherapy in treatment of conversion disorder, blindness and deafness. With the first academic experience, welcome Dr. Chandrani as the chairperson. Next slide,
Thank you
please.
very much, sir. Thank you very much.
Dr. Seema Thakur, Director of Medical Genetics, Fortis Hospital, Shalimar Bagh, Delhi. Visiting Consultant, Rainbow Children's Hospital, Delhi, and Genetic Clinic, Dwarka, Delhi. Academic qualification, MS Obstetrics Gynecology, DM Medicine, Medical Genetics, FICOG. Secretary of DGF, Dwarka, and Senior Executive Member of Prenatal Genetic Specialist Interest Group. Executive Member, SIAMG, Society of Indian Academy of Medical Genetics. Executive Member, ISIEM, Society of Inborn Errors of Metabolism. Member Scientific Committee, Curesme, India. Publication 71, including publications in Nature, Genetics, and American Journal of Medical Genetics. Areas of interest, prenatal diagnosis and genetic counseling, fetal and pediatric syndrome diagnosis, cancer genetics, genetic disorders. She is recipient of Professor 2016-19 by Apollo Hospital Education Research Foundation, Distinguished Medical Luminary Award 2021, IMA Women's Doctoral Association, Delhi. Welcome, Dr. Thakur.
Thank you, sir.
Now please take over. And someone of you has to introduce Dr. Anup Kumar Rawal, our speaker, and someone, and both of you introduce the topic. And now the stage is yours. Please take over.
Okay. So good evening, everyone. It's my pleasure to introduce our speaker of today is Dr. Anup Kumar P. Rawal. He is a consultant at the Clinician and Cancer Genetic Hospital at MedGenome Labs, Bangalore. He is also a consultant at Sahyadri Hospital, Pune, and founder director of Sahaj Genetic Clinics. His educational qualification includes his DM in medical genetics from SGPGI, Lucknow. He did his MBBS and MD in general medicine from MGIMS, Sevagram. He has also additional qualification of MBA in hospital administration from Chennai. He also did DGM in geriatric medicine as well as PGDHHM and CCMD course. His expertise and experience background in the profession includes more than 12 years of experience in medical genetics. He has handled technology in the next generation sequencing and Sanger sequence, MLPAS, PRC, PCRS, CMAS, bioinformatics. He is a member of Indian Medical Association at Mumbai. He has on an average 15 publication of index journal of his interest of subject. He is also invited as a speaker at national as well as international conferences and different CMEs. His area of interest includes reproductive genomics, RSAS, AS, infertility, LAMS, skeletal dysplasia, rare disease diagnosis, and orphan drugs, cardiogenetics, molecular diagnostic for labs, evidence-based medicine, neurodevelopmental and neurodegenerative condition procedures in amniocentesis and CVS. What keeps me going, he said that his genetic lab to bedside gap in the genetics, impact of genetics on patients' lives, research in the molecular genetics, these are his areas of interest. He also narrated about his aspiration to establish a state-of-art center for applied medical genomics to cater all specialty in our medical fraternity. So it's all about introduction of Dr. Anup Kumar sir. You are most welcome over here, sir. Now, Dr. Seema Thakur will introduce us about the topic and its relevance.
So, first of all, I would like to thank organizers for giving me this opportunity. So, as you all know that the genetics there has been a significant advances in past 1.5 decades. So the incidence of genetic disorders we generally say is about 2 to 5% of the population, and majority of the genetic disorders were initially centered around the prenatal diagnosis and the pediatric genetic disorders. But gradually, when the genetics has started coming into the clinical practice, it was realized that about 1 to 2% of any branch, whether it is a cancer genetics, whether it is a neurology, psychiatry, nephrology, there is a genetic component. And gradually the pharmacogenomics came into the way, that where some of these mutation, initially it was considered that the genetic testing is of no use because there is no action or no treatment available because of this or based on this. But now there are many genetic reports which will suggest you treatment as well. So it's high time that we understand when to order what and what are the actionable, so that we can improve the quality standards of the care of our patients. So now with these words, I invite my colleague Dr. Anup to give us a brief overview on the genetics of the psychiatric disorders.
Yes, thank you, ma'am, for the kind introduction. And first of all, sincere gratitude to the entire Psychiatry Association, and particularly Dr. Shobit, for having me on board and granting me this opportunity for this wonderful interaction. So Seema madam has set a very nice precedence. So genetics gradually, as the branch is evolving, it is encompassing all subspecialties.
Do you
Whether
make
it is
full screen, please?
Yeah, whether it is diagnostics, whether it is management, whether it is therapies and ongoing research, which is ever expanding in all directions. So today, my focus will be just to apprise all the psychiatrists with the basics of genetics and how genetics could be important in patient management, whether it is a diagnosis, what family history could be relevant, are we dealing with some genetic conditions or syndromic conditions, whether pharmacogenetics and drugs, when we are prescribing drugs, what could happen. So and latest in research, particularly nowadays, there's a lot of focus on autism. So a bit of genetics of autism I'd discuss in the end. So with this, first, any disclosures from my side. So basically, I'm a freelancer. I'm part-time consultant with MedGenome and Sahyadri Hospitals, and I have my own medical genetics center in Pune. So the motto of my center is Genetics Simplified. So to simplify genetics in all aspects, whether it is clinicians, patients, whether it is management and treatment. So whatever knowledge we can apply for betterment of the patient care. So that's the motto. So as Seema madam rightly mentioned, over past almost like 2 decades, if you 20 years back, if you would have talked of genetics, probably it would have been only about genetic counseling, identifying the disorder, knowing the pattern of inheritance, and then just counseling about the risk estimation and cascade family screening and counseling. So main focus at that time was just about counseling. But over past 20, 30 years, this branch has evolved, and now medical geneticist is like any medical genetics is like any other subspecialty. We see patients in the OPD, in IPD. We have consults from NICU, ICU, from oncology department. So we cater medical genetic consults to all subspecialties, cross references, and we also do procedures. Like ma'am is trained in fetal medicine. Even I am trained, but that's not my forte. I have limited myself only to procedures for my patients. And again, I'm also like medical geneticists are also trained to work in the lab. So of the 3 years curriculum, 1 year curriculum goes in the lab, where we work with the technicians side by side, performing tests by self, like karyotype, DNA extractions, setting up PCRs, molecular tests, and so on. So that's the precedence. And just to provoke a bit of thought and interest, so this was a case that has actually been published in literature. A 9-year-old boy with ADHD and OCD was treated with combination of methylphenidate, clonidine, and fluoxetine. Patient developed low-grade fever in incoordination, ataxia, and seizures. And ultimately, the boy went into status epilepticus and died. So it was so fast that, like, before anything could have been identified. But when the test was done, pharmacogenetic test, it simply revealed that this boy couldn't metabolize fluoxetine. And in a short duration, he had built up very high toxic levels before anyone could recognize, and the child succumbed to this toxicity. So what was the underlying cause, and could it have been avoided? Because if we talk of adverse events, particularly in psychiatry, there are two fronts that psychiatrists deal with. One is therapeutic effect, what dose, increasing, adjusting the dose, that is one. And second is the adverse effects. So are there ways and means with which we can handle this? So historically, genetics has been around for a long time. Origins of behaviors, that was the first research that traced back as 1869 when it was published by Galton. Then modern era around psychiatric genetics, this emerged with the field-defining book Behavioral Genetics by Fuller and Thompson. So here I am restricting to genetics and psychiatry, and how genes or behavioral patterns or familial characteristics, they have an influence on personality traits. This is what is shown. And there has been rapid advances in research using DNA itself. This have fueled greater interest in past few decades. So genes are not about inevitabilities, but about potentials and vulnerabilities. So the era of genomics has just begun. The first specialty or subspecialty to be, floored by it was oncology, because it's all about therapeutics, and definitely reproductive genomics. And now it has started touching other specialties like cardio, neuro, psychiatry is one of them, even ENT, ophthalm for that matter, even orthopedics, skeletal dysplasias, and so on, inborn error of metabolism. So today we'll just, this is the focus points as we go on today. Basic genetics, what is the central dogma, what are the mechanism of mutations, what is precision medicine, molecular genetics. Other topics I'll be just touching upon, maybe in subsequent talks, we can take those topics in more detail. So when we talk of genetics, we are talking of genes, we are talking of DNA. So just to sum it up, human body made up of billions and trillions of cells, each cell having a nucleus where the genomic material or the genome is hosted. So these are nothing but chromosomes, total 46 chromosomes or 23 pairs. So basically it is the flow of information from this DNA, which transcribe into RNA and which translates into the protein. So to sum it up, a body is made up of hundreds and thousands of different proteins. This is a building block. Each protein having a unique function in the body. Somewhere it works as a receptor or cell membrane or connective tissue or enzyme and so on. So all this functionality is monitored by DNA. So any disruption or disturbance or any error in flow of information at the level of DNA or RNA may lead to altered formation of protein or totally absence of that protein or non-functional protein. So this affects the functioning of that protein at that particular organ in the body, giving rise to a particular disease condition or a phenotype. So this is what the basic crux of genetics is. But again, it's not that simple. Lot many sub steps are there when we talk of this flow of information. So there is some DNA modifications that happen at the level of translation or transcription, and multiple steps which are again governed by particular enzymes and so on. So basically a sophisticated flow of information. An error in this is what gives rise to the various genetic disorders. So the chromosomes are placed in the nucleus. If you pull out a single thread from the chromosome, it's the chromatin fiber, which is a condensed structure of the chromatin. You open it up, these are again bound by histone proteins. And again, you pull it out, then it's a double helical structure. And then there are nucleotide base pairs at each end of the DNA. Then there are certain segments in that DNA, what we call as genes, which code, which is the functional part. So in the genome, basically the functional part or the protein coding part is approximately 1 to 1.5%. So if we translate this in terms of data, so each cell has 2 strands of DNA, one strand divided into this 23 chromosomes. So 2 strands of DNA, one strand coming from each parent. So roughly one strand of DNA, it is about 3.3 GB of data. And when we talk of the functional or protein coding part, it comes out to be say 40 to 45 MB. So that's the protein coding part. And one point to note is that this functional or protein coding part is not spread uniformly across the genome. It is spread haphazardly. Somewhere it is very sparse, somewhere it is very compact. So it's very unevenly spread across the genome. So this is the flow of information from proteins are given rise, protein expression, that's the proteome, the expression pattern, what we call as the transcriptome, and whatever metabolites are formed. So that's the metabolome. So eventually all this governed by external factors like so on, give rise to a particular phenotype. So any variation in this flow of information at any step due to any reason will lead to variation in the phenotype or a altered phenotype or maybe a genetic disorder or a condition that we deal with. So when we talk of genetic abnormalities, so what we have seen, it could be at the level of chromosomes. So basically the chromosome number maybe, or within the chromosome, it could be some deletions, duplications of particular segments of that chromosome, or rearrangements which lead to disruption of the genes in that region, or anything that could be submicroscopic, smaller deletions, duplications, or at the level of the DNA, single nucleotide base pairs being rearranged, deleted, duplicated, or inserted, and so on. So genetic abnormalities could be based on the types. To simplify, I'll just give you a corollary. So suppose you have a library of books in your study. So there are 46 books. So every day when you look at it, just by looking at it, you can make out, okay, the library is okay. And by constantly just revising that, okay, book number 5 is double the size of book number 10 and so on. Someday one book is missing, you can just by looking at it, you can make it out, or some extra book is there, you can just figure it out. So this is like, we can compare it to a karyotype. So just by looking under the microscope, we can just see the number of chromosomes that are there, if any number is extra or less. And if any gross abnormality is there, some segment is deleted, duplicated, or some translocated, that can be made out. But there is a limit of optical resolution. Anything beyond that, submicroscopic, will not be picked up. So that is about 5 to 10 MB of the chromosome size. So anything smaller in size than that may be missed on a karyotype. So if you have to look at the library of the chromosomes, the ideal test is to do a karyotype. Next is, if I want to see each book in detail, but to a certain limit. So I see the chapters, I see the page numbers, I see the index, I see the binding. So that is, I'm examining each chromosome, but to a certain limit, not in total depth. So this is like all library books I'm just scanning. So if I'm scanning all, then the test that I use, this is a mid-resolution test, what we call as cytogenetic microarrays. Or if I want to look at particular loci in the genome, or say book number 15, some particular chapter I want to look. So that is like, I can look at it by a test like FISH, that is fluorescent in situ hybridization, or say PCR based test, or I can do MLPS. So these are like whether I want to scan all the library or any area of interest, particular loci. Then we go to reading the book. So this is like reading the entire text. So here I'll be concentrating only on the functional or the protein coding region, which is about 1 to 1.5%. This is scattered across the book. So when I read this region, so I look at abnormalities. So this could be at the level of single alphabet, single word, single sentence, single para, or entire chapter deleted, duplicated, rearranged, so that it doesn't make any sense. So this is like I'm reading through the DNA to look for abnormalities. So this is a high resolution test. So the technique that I use here is either I use a test technique, something like next generation sequencing, if I have to scan for entire protein coding region, or maybe all the entire library, that is next generation sequencing technology. Or if any focus thing I have to look at, like say hemoglobinopathy, HBB gene. So I use a technique like Sanger sequencing, that is the gold standard of Sanger. So this is like from left to right, low resolution, mid resolution, and high resolution. Now there is something beyond this. So whatever we are reading, what else does it does give meaning to it? So this is like the punctuation marks, the exclamatory signs, a comma here, a full stop there. Some alteration will change the entire context of that text, the meaning. So this is what in terms of genomics we say is epigenetic marks which are present on the DNA. So these could be like methylation patterns, acetylation patterns, histone binding. So any alteration in this could alter the functioning of the genes located in that region. So that is epigenetics. So that's how to basically understand the genetics. So low resolution karyotype, mid resolution microarrays, and high resolution next generation sequencing or Sanger sequencing, or whatever technique I want to look at. So the protein coding region, 1 to 1.5%, it hosts about 20,000 protein coding genes. Rest of it is a repetitive or regulatory region, and whatever the interspersed region within the protein coding or within the exons, what we call as the intronic region, that makes up about 26% of the entire DNA. So as of now, about 8,000, more than 8,000 genetic disorders have been cataloged. So there is a online Mendelian inheritance in man, that is OMIM, the catalog that is available. If you want to see for any genetic disorder, the genes, the phenotype, those details can be obtained from that website. It's an open access website. So this is just to give a comparison for all the chromosomes, the largest being chromosome 1, which makes up to almost 250 MB size, and smallest is chromosome 21, so that's 54 MB size. So just to give a comparison, and this distribution is uneven across the genome. So this is how a normal human karyotype looks like. So it's a pair basically, 23 pairs. So out of this, 22 are autosomes, and last pair, it could be either XX or XY, which determines the gender. So total 23 into 2. So that's total 46 chromosomes. Autosomes 22, and last pair, the sex chromosomes. So out of this, each one is coming from each parent. Yeah. So when we talk of alterations or abnormalities in the genome, the word that we commonly use is mutation. But now this word is not being commonly used. The term that we use is pathogenic variants, variation in the genome or variants. Pathogenic is disease causing. So these alterations could be, as we saw in the previous slide, could be at the level of chromosomes. So these are different alterations that have been shown in the graphics. So deletions, duplications, insertions. So this could alter the functioning of the gene which is present in that region if it disrupts the DNA sequence in that region. Or on the right, at the level of DNA, some alterations in the nucleotide. Now we know that 3 nucleotide base pair form a codon, and it codes for a particular amino acid, and each amino acid in a sequence gives rise to a particular protein. So if there is any alteration in the amino acid which disturbs this codon or the code of 3, then this disrupts the message, the mRNA that is being formed, and in turn the protein that is being formed. So this may lead to altered protein amino acid sequence, altered functioning of the protein, or sometimes there could be a premature stop codon that truncates the protein formation and rendering the protein non-functional maybe. So these are the abnormalities to mention. So genetic risk factors for disease development. So there are certain genes which are housekeeper genes, which are essential for the day-to-day cellular activity, cell division, cell growth, and so on. So any abnormalities in these genes will manifest in a particular way. So each gene has some function in the body, whether it is, say, formation of particular enzyme. For example, say factor 8 and factor 9, which are important for clotting. So this gene is located on chromosome X. So any abnormality in the gene may disrupt the formation of the factor, leading to bleeding tendencies in risky conditions, or on exposure, or in the event of trauma. So just to sum up, mutations or pathogenic variants could be at the level of chromosomes or at the level of DNA. So this knowledge is important, because when we see any particular genetic disorder, it is important to have that background knowledge. Okay, if I'm seeing Downs, okay, what is the abnormality at the chromosomal level? It is one extra chromosome 21. Then I know, okay, the test to check for it is to go for a karyotype, or maybe a FISH test to target particular STR regions on the chromosome 21 and see for the signals on fluorescent signals on FISH. Or if I'm dealing with certain monogenic conditions, say tuberous sclerosis, then I know that this particular test has to be, abnormality has to be checked by a next generation sequencing test. Another very important aspect when I'm dealing with any patient having inherited or genetic disorder is the pattern of inheritance. So I'm not going much in detail, but just giving a brief about two patterns of inheritance here, like autosomal recessive. So in this case, like both partners are carrier for pathogenic variant. In this situation, the risk of having both abnormal alleles segregating in the child or in the pregnancy is 25%. 50% of the offsprings, or in each pregnancy, the risk of having a child as a carrier is 50%. And in each pregnancy, the chance of having a normal baby is 25%. So this is like autosomal recessive pattern of inheritance. So here, what is important is you won't get the history of this particular disorder in the family, because carriers won't manifest. But when both partners or husband wife are carriers, particularly in that situation, you'll see affected child being born. So conditions like, say, osteogenesis imperfecta, thalassemia, the most common condition, sickle cell. So these are the conditions. So there is other pattern of inheritance, what we call as autosomal dominant. So in that, like mutation or pathogenic variant, if it is present, the person manifests with the phenotype or the clinical features. And then there's a 50% chance, because in that a single pathogenic variant when present will start manifestation. And then there is a 50% chance of passing it on in each pregnancy. So that's autosomal dominant. So these are classical Mendelian patterns of inheritance. And then X-linked, mitochondrial, or sometimes chromosomal. So if there is a chromosomal translocation or chromosomal rearrangement that is there, which could manifest. So if there's a translocation, then there's a 50% chance that the baby gets unbalanced genome and manifest because of the abnormal gene dosage that is passed on. So when we talk of genetic testing, then depending upon what genetic abnormality I'm looking at, I will have to pick up appropriate test to interrogate that abnormality. So from left to right, low resolution to high resolution, these are the various tests. So karyotype or fish, the resolution limit is up to 5 MBs, microarray up to 100 KB to 5 MB. Now there are high resolution microarrays which can pick up lesser than this. Then next generation sequencing, they can pick up exonic level deletions and duplications, but again, single nucleotide variations, single nucleotide abnormalities can be picked up. Few nucleotide base pair deletions, duplications, insertions can also be picked up. And if I have to look at specific point single nucleotide, then the test or the technique of choice would be like to go in for a PCR based test or a Sanger based test for a few nucleotide base pair loci if I want to interrogate. So over the years, there has been a lot of advancement. So it all started with Maxim Gilbert chain termination method in 1977. Now, then it was refined further by Sanger. And now, as we are talking, so we all know of Human Genome Project, which went on for almost like more than 1.5 decades. But towards the fag end, because of the advancement in the technology, they were able to speed it up. Otherwise, it would have gone for another 10 years. So that time it was first generation sequencing technology that came up. And now we are talking of third generation sequencing technology. And even in this, so there are types, short read sequencing or long read. So now long read sequencing has come up a large way. So Human Genome Project, it took almost like more than 1.5 decades to sequence a single a human genome. And that too, they did only the sequencing. But now we have the capability where in research setting I'm talking of, we can sequence the entire human genome, do the bioinformatics analysis and give a diagnosis in 5.5 hours. So that's the world record, which happened in Stanford sometime in early 2022. So they did a research on children admitted in NICU and PICU, a cohort of 24, and they did all NGS sequencing with diagnosis in less than 24 hours. The fastest was 5.5 hours, and they were able to give diagnosis in I think 17 patients out of 24. So that's the record. So each test has its limitations and advantages. Some overlap is there. The more larger test we do, the more complex and sophisticated analysis, churning out incidental findings. So the complexity increases and also the cost increases. And the smaller tests we do, like suppose if I'm thinking of say achondroplasia or thalassemia, I know precisely what gene needs to be looked at. So I'll be happy doing a focused gene test. So where the pre-test probability for a disease condition is high based on the clinical diagnosis and supporting investigations, the yield for the test is also very high, and it's advisable or better to do a focus test in those situations. And in other cases, when the diagnosis is very not clear or differentials are wide open, in those situations, it's better to go for a wider panel, or which could be like system or disease specific, something like say if you are thinking of lysosomal storage disorder, or if you are thinking of hereditary cancer, then we have panels, or if we are thinking of particular endocrine disorder, or otherwise we can go for interrogation of entire functional domain of the genome. We can do a whole exome sequencing. Whole genome sequencing has also come up and is being offered in clinical setting now. But it remains as a backup test when we fail to get answer by doing other tests. And there's a huge overlap. So it's always good to take help from medical genetics colleague when we have to decide what test to order, what could be the differentials, so that sometimes two conditions may look clinically very similar, but underlying molecular abnormalities could be way apart, and single test may not be able to pick it up. So at times you may require to do more than one test. So in such a situation, it's always good to take help of medical genetics colleague. Otherwise, I've seen situations where clinical suspicion is very strong, clinical diagnosis is made, a genetic test is ordered, but unfortunately a wrong genetic test or a test which is not supposed or not meant or which cannot pick up that molecular abnormality because of inherent technological limitation, and the report comes as negative, and clinicians end up getting frustrated that my suspicion is so strong but still the report has come negative. So such situations may arise in clinical setting. So plethora of tests from right to left. From low resolution we go to high resolution. So it could be like karyotype, FISH, PCR, triplet prime PCR, microarrays, MLPS, Sanger, and NGS. So utility and the condition that we're dealing. So most of the times when the lab receives samples for testing, clinical details are missing. So that's a bigger challenge because genotype phenotype correlation is what is important when reporting is being done. So as much as clinical details are provided, it helps in analysis and reporting. In genetics, most of the preliminary information that was derived was from the genome-wide association studies. So it was like looking at lakhs of single nucleotide variations in 100,000 population and correlating it with a particular disease condition in a population who has it and who doesn't have it, and then doing a statistical analysis as which SNVs are correlating stronger with the particular phenotype. So this led to identification of certain SNVs in certain genes and then understanding of the pathogenesis of those genes. This is how molecular genetics has gradually evolved over the decades. And now we have sub specialties within molecular genetics. It could be like quantitative genetics, looking at polygenic risk scores for conditions like diabetes, hypertension, ischemic heart disease, neurogenic conditions like stroke and so on, risk models. And of course, a lot of literature is being churned out in this field. So talking about psychiatry, these are certain genome-wide studies that I was able to pull out. So ADHD, ASD, depression, OCDs, PTSDs, and so on. And definitely looks interesting. So they're able to identify various SNPs based on heritability. But again, compared to the advances that have happened in oncology, for example, psychiatry for that matter, because of the complexity, inherent complexity, we are still in the nascent phase because most of it is either multifactorial or polygenic. That's the limitation, and certain aspects of psychiatric conditions, some clinical features are seen as a part of genetic syndromes. So for example, like epilepsy or autistic-like behavior seen in a condition like tuberous sclerosis. So that's one example. And also there have been studies which have shown that there is a extensive overlap in common underlying genetic variants between various mental disorders. So this is again beyond genetic correlation. So this is something interesting. And vis-a-vis, across the various genetic conditions, they've seen that pairwise genetic correlations between the major psychiatric disorders. Again, this correlation is also seen. So one is overlap of the genetic variants between the mental disorders, and then correlating between in between the mental conditions. So there's a genetic correlation that was seen. So coming to autism. So few cases where it is a part of like autism spectrum, clinical feature is part of something like tuberous sclerosis or neurofibromatosis, then diagnosis becomes easier, or offering something like a prenatal diagnosis for the couple becomes easier. But in most of the cases where autism, there is no single gene that has been identified, then going for the molecular diagnosis and offering a prenatal diagnosis for that couple becomes it becomes a bit difficult. So lot of research is currently being done. So this was the article which I pulled out, which was published in 2020. So what was important is like multiple genetic variations were identified to increase the risk. Again, there was a cumulative effect. At the same time, there were environmental risk factors which were identified. So basically, it is gene and environment convergence and interactions. And along with that, there are other factors which were found to have influence. So one was this abnormalities in the gut-brain axis in prematurity. So this was one. What was interesting is high copy number variation burden. So that is in mother's genome, high deletions and duplications within the genome. That burden was high. That was one predisposing risk factor that was identified. And again, environmental risk factors were shown to be heritable as seen. So unlike when we deal with conditions like say inborn error of metabolism, where one gene gives rise to an enzyme, or maybe a few genes give rise to an enzyme, any abnormality in that particular gene will lead to deficiency of that enzyme and a manifestation. So in autism, being multifactorial, being polygenic, bit complex, so providing prenatal diagnosis or identifying the pattern of inheritance again becomes difficult. Again, there is one more aspect to it, that was like the phenomena of epigenetics that was noted in few studies, particular methylation patterns across the chromosomes, which showed a higher preponderance for development of autism in the cohort. So world over, the genetic yield or the success for diagnosing the genetic cause in autism cohort has been between 8 to 13%. But recently there was one study which was published from Gujarat, which showed that if you did a whole exome trio, this yield increase up to 30%, and they identified MACP2 as one of the common underlying abnormality in this patients. So this study they did 101 whole exome trials, and in about 3% patients they identified copy number variations. But again, this is a singleton study and needs to be replicated. So this could be a bias, a referral bias, this being a tertiary care center. So it needs to be interrogated and replicated in other centers as well. So this was one thing I was mentioning about autism epigenetics. So basically either de novo mutations in the synaptic genes or congenital abnormalities of the epigenetic control. So basically the plasticity of the brain during the development being affected by the epigenetic abnormalities leading to abnormal switching, or in addition with the additional factors, environmental factors, again having an influence of this on this, leading to aberrant expression of the synapse. So basically, structurally the brain is normal, but at the synaptic level, aberrant expression leading to synaptic autism. So the functionality of the brain being affected. So this is the underlying abnormality due to epigenetic causes. Again, so epigenetic programming happens during pregnancy, and there are many factors which influence this prenatal epigenetic programming. So like placental dysfunction, maternal nutrition, oxidative stress during pregnancy, exposure to toxins or teratogens, infections during pregnancy per se. So we saw previously the gut-brain axis being affected, maternal metabolism or imprinting, which are passed on from either parents. So same thing, giving rise to autism in the baby. So when we talk of genetics, we've seen like the information being passed on from DNA through the proteins, metabolites, metabolome. So at each level, there is a method of interrogating that information. So what we call as the omics. So when we are interrogating the transcriptome, the protein expression pattern, it's transcriptomics. If when we are interrogating the entire protein that is being formed, it is when we are looking at the RNA, it's the transcriptomics. When we are looking at the protein that is being expressed, it's proteomics. When we are interrogating the DNA per se, it's genomics. And when we look at the entire metabolites or molecules or biomarkers, then it is metabolomics. So each has its role. Sometimes one particular method may have an advantage over the other. So all have to be used in conjunction. Each have their own limitations and advantages. So coming to pharmacogenomics. So sorry, there have been some shuffling of slides. So functional neurogenomics is one concept that has come up very recently as one of the cause for autism. So this is very interesting, where a rare and common genetic risk for ASD is being studied in the research setting. So just to list a few conditions where psychiatric manifestations are prominent features. So Wilson's, Niemann-Pick, and all these are monogenic. So there are a lot many conditions. I have just mentioned a few because these conditions can be identified based on the clinical examination. For say Wilson's, history of diabetes, hepatolenticular degeneration related features, and so on. So Darius disease, childhood onset schizophrenia. So these are all monogenic. Most of the times, if clinical features are not very prominent or history is not very yielding, molecular diagnosis may not be anticipated, and the exact diagnosis may be missed in these situations. So coming to genomics or pharmacogenetics. So basically, over all the years that we studied, we know that when we give a drug, either the patient gets optimal therapeutic benefit, if therapeutic efficacy is there, or at times the patient, some chunk of patients, they get side effects, or a few patients, they won't get either side effect, but at the same time, they will not get any benefit of it. So basically, when we're talking of pharmacogenetics, I'm talking of pharmacokinetics and pharmacodynamics. So how the drug is metabolized in the body and how it is excreted. So basically, to simplify, if I give a drug, it is neutralized or deactivated in the body and excreted. So that will limit the therapeutic effect. And if I give a prodrug, which needs to be converted, and then the therapeutic effects are supposed to be delivered. So if this step, then active drug will not be formed and the patient will not get any therapeutic efficacy. At the same time, if prodrug has some side effects, or if active drug has some side effects and needs to be broken down and neutralized, if that step is not happening, there's a risk of the person getting exposed to the side effects for that particular drug. So there has been a lot of questioning regarding, do we have any such data from Indian population? So yes, we do have. So look at the percentages here show the frequency of poor metabolism phenotype. So of interest in psychiatry, primarily CYP3A4 is the drug metabolism enzyme that we'll be looking at. In this case, CYP2D6. So particularly drugs for fluoxetine, amitriptyline, codeine, nortriptyline. So in the first case, basically the child had a deficiency for CYP2D6 and was not able to metabolize fluoxetine. So that was the underlying reason. So this is what we have seen pharmacogenomics. So classical example is from cardiology, where it works, clopidogrel, where it is inactivated, and if this pharmacogenetic risk is there, then the patient could have life-threatening bleed even with normal or suboptimal doses of these drugs. So that is one example. So again, in from psychiatry point of view, what is of interest is based on the mechanism drug exposure. We often have situations where we have to follow up patient for a longer duration to have that therapeutic effect. It takes longer time to have dose adjustment for those patients. Most of the patients have are on multiple drugs. So at the same time, if the patient is taking multiple drugs, there could be a risk of drug interactions. Even all these aspects could be predicted based on pharmacogenomic testing. So this was one study which showed that pharmacogenetic testing for clozapine, it could have help in increasing the efficacy in treatment resistant schizophrenia. Again, microRNA study is something which is coming up a large way, particularly for psychotic disorders. So this was one study which showed that for one particular microRNA, MIR181B, it was found to be positively correlated with amelioration of negative symptoms when put on therapy. So even prediction for prognosis and how the patient will fare, this information could be obtained on pharmacogenetic testing. So as we are heading forward, what looks more practical, or what could be the focus of interest, is having a interdisciplinary practice where patient visits pharmacogenetics consultant or clinic, particularly to start with those patients where we are not getting optimal efficacy, or those patients who have suffered serious side effects, to ascertain or diagnose the underlying cause, what could have led to the adverse event. And when we talk of genetic testing, it is everything is done from the blood. So it is simple blood draw. We separate the white blood cells, extract the DNA, and do the study. So coming to the crux of the medical genetics as a clinician or as a practice focus. So in all subspecialties, we see a patient, we investigate the patient, and we treat the patient. But in genetics, one more aspect or dimension is looking at the family, if it is inherited. Are there any other individuals, first degree, second degree relatives, who are at risk for this particular condition that we are dealing with? Whether it is a psychiatric condition, cancer, cardiac condition, which has a genetic abnormality which is being inherited, and could we prevent it from being passed on to the future generations? So there could be options which could be offered, like prenatal diagnosis by, say, amnio CVS, or if couple is willing, could we offer them IVF, and where we could do the testing on the embryos and check if that abnormality is there or not, screen the embryos, and probably take the healthy embryos and the pregnancy continues. So that is one option that can be explored in appropriate clinical setting as per the guidelines and evidence. So to summarize, psychiatric disorders are multifactorial. Psychiatric genetics is still in early stages. I think pharmacogenetics is something where it has picked up in a large way, but how it is being absorbed in clinical practice, I think we just need to have much more experience as we go ahead. Then most genetic risk variants affecting major psychiatric disorders remain to be uncovered. So when it comes as a part of genetic syndromes, it becomes easier even for medical geneticists to identify those conditions. Isolated psychiatric conditions, yeah, there is a lot of scope of research still. Several psychiatric disorders still lack sufficiently powered genetic data. I think probably this is due to on two fronts. So lack of medical genetic experts in the country and interdisciplinary practice interactions that need to happen. So integrated analysis of the full range of genetic variation is necessary to provide comprehensive understanding of how genetic variants influence the risk of illness and underlie different clinical profiles, warranting greater use of sequencing technologies. So what is more going ahead is for more complete understanding of underlying causes of psychiatric disorders and account for substantial individual variation, we need to do deeper phenotyping. More clinical delineation needs to be done, along with incorporation of demographic and environmental data. And we need to identify gaps in this areas and do focus research. So probably it's high time we take a call for more collaborative approach between the clinical genetics, molecular genetics, and fields like psychiatry. Thank you. With this, I'll be happy to take any questions.
Thank you so much, sir, for enlightening us. I'm referring to chairpersons now for their opening remarks.
Sir, I have copied few of the questions from the chat box. And this includes...
Dr. Kalpesh, before that, any
remarks
comment
from
your
you
side?
or Seema,
or
ma'am?
Dr. Seema?
Yeah, so a very clear presentation, Dr. Anu. So it was really a sahaj understanding as you simplify the genetics. So basically, I feel that, a clinician, those who are practicing into the 21st century, this is like, the computer for everyone, like it was earlier. So we have to know the genetics. Every clinician has, because genetic testing has reached your doorstep and it has become cost effective. And more or less, it is going to be direct consumer testing in these commercial times. So the labs have reached. So as a clinician, when you are confronted with a genetic report, we should not sound like, we are not knowing, or like that. So it's a high time that every clinician should know. So basically, we have about 46 chromosomes, and we have, on these 46 chromosomes, we have about 20,000 genes. So most of the clinicians working in the, in the different branches of the adult genetic disorders, they mainly encounter the single gene disorders. Very few of them will be the chromosomal disorders like Down syndrome or 22q deletion. They also present with the psychiatric manifestations, but majority, they will be like, the monogenic disorders, and you have to identify from your routine clinical practice. And the presentation will be simple only. It will be, simple, the mild dementia, adult onset, and forgetfulness, and mild ataxia. And from this, maybe you can say 1 to 2% or 2 to 3% will turn out to be the monogenic disorder. So somebody has asked what test to order. So as a clinician, you should always remember that most of the time it is the single gene disorder, and the test of the choice is whole exome sequencing. And that is very, very cost effective, to the tune of 10 to 15,000 by different labs. And the turnaround time is about, about a month. So this is how, and why it is important for you, because now clinician, for them, it's not only about diagnosis, it's also about, the treatment. So many of them are actionable. And also when you give certain side effects, which Dr. Anup has discussed. So with this, now we move on to the questions in the chat box. So the first question is, I think Dr. Anup would answer. The first question relates to the genome-wide association studies for all these multifactorial psychiatric disorders.
Sir, please unmute.
Just to simplify how this genome-wide association studies work. So the labs, the scientists, what they do, they identify basically single nucleotide variants across the genome and it's in huge numbers. They'll look at 1 lakh SNVs in one go in an unbiased manner. And they will look at the same SNVs in 100,000. So the population cohort is also very large. And then they will correlate, okay, which cohort amongst the sub group analysis, which group has the clinical features and has that particular SNV as well. And then they'll try to do a statistical analysis and find out which SNV is correlating with the phenotype and not. So this is totally unbiased. And once this is how, so the classical example is like BRCA1, BRCA2 with breast cancer. This is how the SNV were identified first, and then they've identified, okay, this SNV is in this gene, and then they studied the molecular pathomechanism, and then they identified, okay, this is one of the DNA repair gene, and then this abnormality gives rise to the cancer. So this is one of the unbiased method of seeking the SNVs, also then identifying the gene, and then further going ahead with what could be the pathomechanisms. So that's how it is.
In routine practice, we would not come across the genome-wide association.
So that is a research
but
tool.
mainly for the institutes or those who are working in the research area. So they would identify candidate genes. Like if they have to study for autism, they will be looking for all the genes related in the brain development, and then they will see the control and the cases, and accordingly, as Dr. Anup has. So, but as a clinician, you will not get chance to do the genome-wide association studies. You will mainly need to do the testing, which is practically, the single gene testing. Now, the next question.
Ma'am, just to, so Dr. Anup, I think you presented what we asked, like a very basic presentation. So I must congratulate you. I think for the audience, very simply speaking, when a patient comes to the chamber, when should we order a genetic test?
So I'll go one step even back on that front. Even before ordering a test, I would see a situation: is a medical genetic consultation possible? Because what happens is there are certain clues when we see a patient. Family history, okay. Off note, negative family history may not be important. Most of the times we have a habit, there is no family history, so leave it. But that may not be the case. If we are dealing with, say, X-linked recessive or say autosomal recessive condition, family history may not be there. Or people may have succumbed before being manifesting the condition. So that is one. Second, looking for neurocutaneous markers in those patients. Looking for unusual presentations. Typically in such families, you'll get history of, say, recurrent miscarriages, history of developmental delay, some developmental delay in the child, some behavioral changes. So we need to look at all these aspects. So frankly, Shobit sir, you tell me, how many times do we delve into detailed family history, say up to 3 generations, horizontal and vertical, for any patient? So I would suggest that if there is a reason to suspect, please go in for a medical genetic consult. If you're seeing any of the red flags that we discussed, that is the situation where you might want to order a genetic test. Next, the question comes, which test? So basically it is all on the phenotype. So whole exome sequencing is a blanket test. I've had patients where clinically the patient walks in from the door, from the gestalt and the behavior, I'm able to make out, okay, this is Angelman. And he has come with a whole exome report in the hand, which is negative. So then it becomes a difficult situation. Someone has already ordered a test that is not supposed to pick up the methylation defect. The report will be negative and the clinician is frustrated. ये तो दिख रहा है मुझको पर इसमें नहीं है. So if we can combine a medical genetic consultation, it will make job much easier for you, for the patient as well. And now lot many people are doing online consults as well. So that option is also there. I hope I've answered your query, sir.
Yeah. So why not? Then now, okay. So we have to order a test. You have actually specified in your presentation, like, very simply for the audience benefit, which test and when. Though you have actually answered it, and I think
Sorry, sir. There is some
hello.
So
my
Dr. Shobit
computer.
is asking.
I think, sir, Seema ma'am, you can take this up.
Yes. So regarding your first question, which I tell to every clinical, clinicians these days, that, whenever how to suspect a genetic disorder. So two questions one must ask. One is the family history, and one is the history of consanguinity. And then of course your clinical examination. So these two are the basic. It should be whenever see a patient, whether you are suspecting a genetic disorder, because this is how you can pick up more, and a high index of suspicion should always be there, because we have seen the cases of Niemann-Pick disease presenting at 35 to 40 years of age. We have seen CADASIL presenting as a psychiatric illness, adrenoleukodystrophy, and initially it was being treated with all those psychiatric medications, and finally somebody did the whole exome sequencing, and then that report come, and then that patient we could see. So it's because you are following up with the patient, so you can easily suspect, and high index of suspicion. And then the test of choice, as I discussed, for most of the clinician, it is not the microarray or the karyotyping testing. It is usually the single gene disorders, and whole exome sequencing is the answer for everything. It includes all 20,000 genetic genes, out of which 8,000 are known to be disease causative by the OMIM. That OMIM is online Mendelian inheritance in man. So whenever you get a report and you find out that there is some report, some genes, then they will give you some OMIM number also. Just write down this in Google, and you can get to know all the clinical symptoms, whether they are present, and you can match with your patients. So this is how we go about it. And also, as Dr. Anup has very, so pre-test counseling, initially you will be requiring us, but usually in the post-test counseling, I would suggest that one must consult a medical geneticist, because they not only give you the discuss about the reports, but they also discuss about the other preventive measures for the next generation. Like you may have somebody with cancer genetics, or maybe with Huntington chorea, and so the next generation. So everything that needs to be, not only the family planning, it's also about your life planning. Somebody would come to me with Huntington's chorea, and I said, see, why do you want to get the test done? There is a 50% risk that he said, I want to plan my life, whether I want to go ahead with the marriage, whether I should do this study, whether I should take part in this sports or not. So there are lots of planning, not only the family planning, the life planning also. So these people are coming forward. So it's high time that as a clinician, we should not sound like that, we are not aware of it. And and the patients are very smart to make it out that you are not aware of all of this. So we should all know, we should know about the basics of the genetics, and when to order what. And the best test is for all clinician is the whole exome sequencing, and that is the solution for everything.
Dr. Kalpesh has asked me how much is the
madam.
cost?
Yeah,
It
approximately.
varies from 12 to 14,000. The cost has come significantly down. It started with 35,000 when we started, and now it is the whole exome sequencing. Sometimes you can also do the clinical exome sequencing, where only 8,000 genes which are known that disease causative in the OMIM, that only can. But for that, when I'm very, very, particular about the diagnosis, then only I order. And then this will only check the point mutations only. But if you're suspecting like Frederick ataxia, that is a repeat expansion. If you're suspecting Fragile X, that is a repeat. So for the repeat expansion, the test is different. So you have to order accordingly like that. So
when should we order this whole genome, ma'am?
Whole genome, yeah, that has started. I have personally not done any as of now. The test is very, very expensive, but they say that it includes everything, not only the coding part. Whole exome is for the all the coding part of these 20,000 genes. The whole genome includes even the introns also. That also includes the copy number variations. So it also includes the repeat expansion. So that is a one-stop solution for everything.
It is
But that
broader.
will
So
take some time.
I'll
That
just
will
add two points. What Seema madam has already said. Thanks, ma'am, for putting it straight. So we should remember that 85% of the genetic abnormalities in human genome, they lie in the protein coding region. So doing a whole exome sequence makes a lot of sense because 85% of the times you'll get the answer. But having said that, what are we dealing with? Our clinical suspicion, our clinical diagnosis, that has to be very proper. Just last week, I had one patient, autism. A couple came for, a mother was pregnant. They came for prenatal genetic consultation. She was like around 10 weeks. Child is under treatment from a psychiatrist. Child is like 7 years. Severe autism. I examined the child, and to my surprise, I was able to see Ashliff macules. I was able to make a clinical diagnosis of tuberous sclerosis. His MRI was done, which was surprisingly normal, no tumors anywhere. I examined the father. Father had chagrin patch. Okay, and they came with a whole exome report, which was negative. So I said, okay, I know now it's TSC2. I know where to look for. I did a MLPA for TSC2. I found the abnormality. I said, okay, I know what the abnormality is. In next pregnancy, we can do, like now the current pregnancy which is going on. Now we have planned for amniocentesis at 16, 17 weeks. So sometimes whole exome may miss. So you have to be very particular when to order, when not to order. And as ma'am said, sometimes it is triplet repeat, sometimes it is methylation defect, sometimes it is imprinting. So in those particular, though this the percentage of this cases is less or rare compared to other abnormalities, we have to be aware when to order or better to take a. And one more point I'll highlight is pre-test genetic consultation and counseling, because post-test, what all scenarios could arise, we discuss with the patient. So that doesn't come as a shocker for the patient later on. So they have to be primed. Otherwise, directly doing post-test genetic consultation counseling sometimes becomes difficult. Patient may be in denial. So such situations do arise.
And in context of the same question, there is a question in the chat box that many a times in W whole exome sequencing, the report is pathogenic variant of uncertain significance, which we just encountered in one of the patients, which we also sent.
Yes.
Like how to then interpret it and then how to go it, whether we'll go for whole genome then, or maybe something more specific.
Yeah. So VOUS, variant of uncertain significance, it is basically a nightmare for medical geneticists like me who do reporting with the lab. So when we do reporting, whatever variants are put in the report, they have been interrogated against attributes. So there's a ACMG criteria that we apply. Now we have graduated to clean gene criteria. So what is the interpretation of this variant as per in silico analysis? Is it already reported in some databases? Has there been any functional studies that have been carried out? Is this particular variant or this particular loci, is it conserved across species? So there are various parameters through which we put this variant, and then we do a scoring, and then we identify, okay, is it disease causing or not? When we say pathogenic or likely pathogenic, that means the probability for this particular variant to be associated or to be disease causing is more than 90%. So that is what we are talking of, the confidence. So most of the times the clinical feature may be matching for this particular gene, but this variant may not be reported. It may be a missense, and we don't have enough evidence or at that particular point of time to say that it is strongly, to say with confidence that this is causing the disease. So in that situation, we label it as uncertain significance. So for this cohort of patients, we need to follow it up, maybe 6 monthly or annually, and then check with the lab. Has there been any updation in the evidence? Is the variant being reclassified? That we need to follow. And in some cases, we also need to do additional studies. Sorry, I forgot to mention this, like segregation, testing of the parents, testing of any additional family members who are affected, unaffected, and then that also again adds to the scoring. So most of the times once NGS report is done, so this is prior to the segregation. So segregation may add further points and may change classification at times.
Okay, can you elaborate the most cost-effective options for the labs? Because we, like in my case, we're in Dehradun, so the labs are not available here. So the options which I think the audience can benefit and their contact details also. The most
So, sir, conflict of interest. I'll request Seema ma'am, please. Then I'll put my names
Commercial
later.
labs, they are
Yeah.
available everywhere. They are available
So,
everywhere. We can share your Delhi number, and that Delhi number will reach next day only to your Dehradun. So they are everywhere. They are, so
because,
don't need
So
to
there are,
go.
yes,
ma'am, for
there
this
are
also,
labs,
do you need only that saliva sample? That's it?
No, blood
blood.
sample, EDTA blood sample.
So,
Blood
Shobit
sample.
sir, to your question, thanks Seema ma'am for that input. So there are labs everywhere in India. I won't take names, but what you should be asking the lab is, are they NABL and CAP accredited? That is one. And what is their internal database that they're looking at? Second. Third, who's doing the reporting? Who is the signatory? There should be a medical geneticist, either a DM or DNB medical geneticist who is signatory and who has seen and checked the report. That should be the third important, because most of the labs are just like booths. They're collecting the samples, outsourcing it to third party, getting the data, doing the reanalysis, or getting the entire report and just printing it on their letterhead and giving it to you. What happens in such a situation later on, if you have a VOUS or you consult some geneticist and they want to look through the data, these labs may not be able to provide the data. Then that becomes a logger jam because you're stuck. Patient has paid, test has been done, report is in your hand, but if you want to reanalyze, we can't do it because data is not there. So we have to be careful on this front. So NABL, CAP, signatory, data being made available, these things we need to check with the lab. And logistics right now is not a limitation anymore. I do online consultations. I have patients coming in from South Africa, Middle East, any part of India, even Srinagar, Leh. Labs are able to pick it up. So that's not an issue anymore.
And one more question, that facial dysmorphisms, is it also
Yes.
one of the indicators for going for genetic
Yes,
tests?
it's a strong indicator. So that is what I mean by gestalt. So certain genetic syndromes, like if I'm talking of say Prader-Willi, Bardet-Biedl, 22q velocardiofacial Williams, or say Wolf-Hirschhorn. So these microdeletions or microduplication syndrome, or even certain monogenic conditions, they have these patients have typical facial appearance based on which we get a clue and we pick up the diagnosis. So dysmorphism, if it is there, if you are able to figure it out, very good. Otherwise, you can ask for a genetic consultant opinion. And in such cases, even online, consultation works, because sharing photographs, sharing videos, it helps. And if anything physical examination is required, we can take help of our colleague who's there by the side of the patient.
I wanted to ask, there are now
Yes, sir.
a lot of labs talking about pharmacogenomics for drugs. And I've got it done for 3-4 patients. You have this green, yellow, and red. How good this data is, how relevant it is for our practice, because that is much. Because some patients who are very treatment resistant or very having a lot of side effects, nothing working for them. I mean, both ma'am and you can answer if
So
because
if may I ask which lab that becomes important?
So Agilus does.
Mhm.
Agilus, which is used to be a Religare Renit and Baxi lab, that does. Agilus does a lot of testing. There is a lab in Hyderabad called some MyDNA. I've got few tests done from them also. So I wanted to understand, because this and they're adding. So one, I got it done a couple of years ago. There are only few drugs. Now the panel of drugs have increased a lot more.
Yes.
And apparently it is for life. So once you get this 10-15,000 done, all kinds of medicine, hypertensives, antibiotics, everything under that 15,000. It's supposed to be valid for life. So is it really good, or is it just fad?
So two things again. Which lab? So Agilus, I have my reservations. So
Okay.
Pharmacogenomic, I doubt they are doing it in-house. They're outsourcing it. They themselves are not doing it. Agilus is not
Okay.
doing it. So we have to be careful. Then DNA labs, you said, yeah, they're doing it in-house. Secondly, what platform they're using? Some labs are doing it. Most of them are doing it on GSM, microarray chip, and they're doing the reporting for pharmacogenomics. Some labs do it on NGS. So if so GSM based is cost effective, robust, because you just have to look at the genotypes, what is present in the patient, and based on that you can give interpretation, because the list of drugs can go on increasing, because the pharmacokinetic and pharmacodynamic information of that drug is already available. You just have to look at the genotype and then you have to extrapolate the phenotype. So is this gene functioning, over functioning, or hypofunctioning, or not functioning at all? So suppose CYP3A4, if I'm looking at where all my beta blockers, antipsychotic drugs, they get metabolized. So if this CYP3A4 is hypofunctioning, then I know the drugs I need where a prodrug is getting converted into active drug molecule for a hypofunctioning gene, I need to give a higher dose.
Right.
And I think, sir, you have aptly mentioned.
This is a active
how
drug
the-
which is being converted into, so then there is a risk for side effect.
And you have aptly mentioned how to screen a lab, the various
So
parameters.
if you are doing a test,
Yes,
sorry,
that,
so
yeah, go ahead.
any lab person coming to you, you can ask them for NABL and CAP, that is one, and who's the signatory. Most importantly, you should ask them that are they doing the test in-house? Because some labs, what they do, they don't do it in-house, they outsource it, but they put it on their letterhead and nowhere they mention. So most, even for pharmacogenetic test, best is to ask them, tomorrow if I want the data, you should be able to give me data. So only those labs who are doing it in-house, they'll be able to give you the data.
It's good idea to ask data from everyone. You may
So
require this in future.
you
Otherwise,
automatically filter
okay.
out those, yes, labs which are not doing it.
So, but we should go ahead from with a good lab. There's no harm in getting pharmacogenomics done.
Yeah, pharmacogenomics will help, yes. Particularly when multiple drugs, polypharmacy. And just to name, like Newberg is there, Radcliffe is there, Medgenome is there. These are few labs. Strand has also come up. They are also doing. Ma'am, any more names you want to add?
These only.
Yes. So there are a handful of labs.
Newberg, Radcliffe,
Any important questions in the chat?
Medgenome.
Medgenome.
Sir, what is your experience related to the neurocognitive disorders and its inheritance and its diagnosis by genetic analysis? Do you often get such things?
Yes. So very often, particularly when it comes to planning pregnancy. So I get most of my patients when one child is already affected. So rather than diagnosis for the child, the couple is concerned with the next pregnancy being affected. So that is the situation when they come. And in my clinical experience, what I've seen is like when it is neurological, when you have evidence of, say, epilepsy or MRI findings of some structural abnormalities, delayed myelination or white matter disorder, and so on. In those situations, the diagnostic yield is very good, almost like 60-70%. But when it comes to neuropsychiatric conditions, particularly where the psychiatric symptoms are predominant, the yield in my experience is less than 10%. Again, having said that, I will also acknowledge that I am not able to do whole exome trio in those cases because of the cost. The patients coming in from, limited, poor socioeconomic status. So that could be one reason where I'm missing the diagnosis. Ma'am, your experience?
Yeah, like, for the autism, I hardly get any single gene disorders. So a couple of cases of Fragile X. So mainly whenever there is a, behavioral and the psychiatric manifestations predominating, then the yield is low. So before doing the test also, we inform them that it may not be more than 5 to 10%. And also some of them may be treatable. We may get to find some gene which is actionable. So this is how we convince them. And also many a times, they are not ready to undergo the genetic testing, that there is no, and citing that there is no family history, so why should I go ahead with this? So then we can tell them, see, 90% of the genetic disorders, do not run in the family. They will happen for the first time in that family only, because it's a genetic disorder. They would take this as a stigma. So, bypassing, avoiding the genetic consultations, avoiding the genetic testing. But we can, as a clinician, when we know that, this is important, irrespective of the family history, still this can happen. So all these things are important for, when we talk to them, because
Thank you, ma'am.
I think we are up on time. So what to do actually? How to help the patient in management? What are the things in management that are that can be held upon by way of genetic testing and analysis?
So one is delineating if it is a isolated, basically primarily a psychiatric condition, or it is a part of a larger syndrome that we are dealing with. So because entire the scope and spectrum of management will change in that situation. Secondly, the risk of recurrence in next pregnancy. So that is second point. Third is like if it is due to a genetic etiology, and if it is syndromic, what is the risk for any other organ system or any complications that we should anticipate going ahead? Can we plan baseline screening, testing, and preventive strategies or management based on those? For example, say tuberous sclerosis. I have a family now. So the child, apart from neurocutaneous markers, MRI we have done is normal. Only full-fledged like severe autism, it's like refractory whatever therapies have been tried, no response. But now I know that father is also having the same variant clinically. It's yet to be proven by a molecular genetic testing, and I will be offering prenatal diagnosis because I have got the child's mutation. So I can see to it that like the current pregnancy, we can do the testing of the fetus and find out if the fetus is being affected or not. Here the risk is 50%. So this I've counseled. I'm just waiting for the time so that they cross 16 weeks. Then we do the amniocentesis. So holistic, like overall management, apart from the individual, other members at risk and the family. So here I have also alerted the husband, the father of the child, to get his siblings tested or at least screened clinically, because I think his one of his sister has history of recurrent miscarriages. Now, could this be related? Needs to be seen. So it is like applying this for the management of the entire family. Now the scope keeps widening with every genetic test and every information that we have.
yeah. So, end of the diagnostic odyssey, the most important part is that now you can level them with one particular confirmed diagnosis. Then, with the confirmed diagnosis, you can counsel them regarding the prognosis. Like, suppose in this case, tuberous sclerosis. So, you can counsel the family about what all this disease is, and how this will behave in the future. It's not only about the reproductive counseling, it's about the whole life, planning. Then for the recurrence risk, that whether there is a risk of 25% or 50%, and what are the ways to prevent. There is a CVS, there is a pre-plantation genetic testing. So this is a very good, testing technique to, deal to discuss with all the patients, so that they are benefited the most. And the genetics has reached to a stage that, where, to reach to the masses, I must say. And then we must start including them as a one of the standard of care, rather, instead of, last test. It should be a part of the standard of care, like in cardiology for the hypertrophic cardiomyopathy. This is a standard of care, like in the nephrology. So it should be, gradually included as a standard of care, and so as to benefit multiple patients, and in a maximum way.
Okay, so I think we need a more detailed session on management aspects.
Yes.
So if you can request
As
to
a
us.
clinician, your interest would be that only.
Right.
Yeah. So because this was just a basics class, so if we can get something on how our management protocols can be updated.
Yeah,
Yes.
brilliant.
So the neonatal
Yes, yes.
seizures, the immunology and all, they would identify, and based on that, they will treat. Based on the genetic mutation, the drugs are different. So that's actually very, very interesting. The moment the type of mutation, the type of gene, you can change your medication, and you will see drastic change. I have seen neurologists in few conferences, and they have shown those videos that how the patient was before the genetic testing and after the genetic testing. The change of the drug has remarkable progress, remarkable changes in the quality of life. So this is how the power of the genetic testing it has, and so that you can empower yourself and your patients by all these knowledge, and including them.
So I hope we can meet again, all of us. Yeah.
Yes,
Looking
yes.
forward. Yes.
Discussions will go on.
Yeah. So any final comments? Then we can close the session. From the chairpersons, any final comments?
I think it was a good interactive
Thank you very
session
much, sir.
between the geneticist and the clinicians, and we look forward for more such sessions, so as to both of us are being educated in this way. Your questions give us inputs that what else you need more to improve to a different level, and to escalate our knowledge to a different level. So it's bilateral interaction which help us both of.
Thank you. Tufan sir, over to you. Then
Dr.
Amrit.
Amrit sir wants to say something, I think.
Yeah, first Tufan sir, then Amrit.
Thank you. Thank you very much, Dr. Anup, for your nice enlightenment. And just one inquisition, not a necessary question. What is the percentage of genetic testings we do for therapeutic or treatment purposes in proportion to the whole array of genetic testing that is being done?
So this I will segregate it specialty wise.
Yeah.
So if you're dealing with inborn error of metabolism, around like in 30-40% of the cases, you're able to change the treatment strategies based on your results. When it comes to onco and you're doing molecular genetic testing, this goes as 80-90% based on which mutation, which targeted therapy you want to apply, whether it is lung cancer, colorectal cancer, breast cancer, prostate cancer, even prognostication and all. So this varies with the specialty. In cardiology, it is more about prognostication and anticipating complications when we are doing the genetic testing. So it's a difficult question to answer, sir.
But
What
yes,
is the
many genetic disorders are treatable these days.
Prevent.
Like
Yeah.
asthma, so the treatment for SMA. So it's coming
Yeah,
up. Lot
treatments are
more to be done
coming.
in the therapeutics. So when the clinicians would join, the drive will be towards the treatment based on this diagnosis. So I think
Yeah, many barriers are still there. We need to come together
gap
and
between
fight the
us
barriers. Yes.
is going to be lesser and lesser.
Another inquisition, what are the legal and ethical issues involved? And in India, is there any legislation regulating genetic test platforms?
So ethical. So yes, consent from the patient, if he's above 18 years, below 18 years, consent from parents that needs to be taken. So that is one. Second, most of the legalities involved, they are with respect to reproductive genetics when we do prenatal diagnosis or embryo biopsy, IVF. So it's pertaining that the PCPNDT and ART rules. Regarding genetic testing of adults for neuropsychiatric conditions, cardiac
About the
conditions,
data privacy,
there is no
how much
regulation or
these
rules.
platforms ensure data privacy?
So yeah, data privacy, this is
We are
subjective.
not concerned, but these platforms are concerned.
So labs, so most of the labs, they do save the data, but they anonymize and save it. You have an option when you're signing the TRF that you can request the data to delete So request the lab to delete your particular data. So that some labs offer that option, or you can say, tell them, you give me the data and delete it from your record. So that option is also there, but most of the people are not aware. They don't exercise this
Also, they
power.
don't share the reports with anyone else, either
Yeah.
with the patient or with the clinician.
Or with the clinician. So
How they
suppose
want
like
to
Seema
maintain
madam
the
has seen a patient,
Yeah,
and
so he
that
cannot
patient
have
comes to me for a cross consultation. I can only see the report. I cannot get the data. So I have to talk to Seema madam ki ma'am, I need to reanalyze the data. Can you please put an email and CC me? Or the patient then has to talk to the lab and tell ki Dr. Anup wants the data, please give him the data. So that is very strict. No one else has access to the data
no one
and
else can
even the
take it.
reports. Yeah.
The reports will only go to
Even
the
from the
clinic.
same family, if the patient's brother or sister they come, they will not share. So that is very
Yeah, they
strict.
will not share. Yeah. The same
Okay.
is with
Until
us
unless
also,
the
we
patient
don't
permits.
discuss.
Thank you very much. And over to
Thank you,
Amrit for
Amrit.
their final questions and summing.
Thank you
Closing
so
the
much.
meeting.
Thank you so much. I'm, the basics of genetics. I think we were like, it is one of the most important things. If you really want to understand, and there are a lot of now companies coming out with genetic tests, and mostly in terms of therapeutics. If you come to psychiatry, it is in terms of therapeutics. And now 2 or 3 genetic scans are coming where you can actually predict which drug is going to work and which drug is not going to work. So that's a very interesting addition to psychiatry treatment. And I'm very thankful to Dr. Anup K. Rawal, who made such a complicated thing very simple. And as Dr. Alim was telling, we need to meet again. We need to call them again to a musings for further, discussion on complicated things. Dr. Seema Thakur, as a chairperson, has been wonderful. She has been proactive. She has been answering a lot of questions. She has been taking and giving a lot of inputs. And Dr. Kalpesh Chandrani also, we are thankful. So all in all, it has been a wonderful session where we are talking about basics of genetics. And as we go ahead and ahead in terms of, in terms of research, in terms of treatment, I think genetics will play a very important role. And if you don't have a good basic knowledge of genetics, we will be, caught napping. So I think I would congratulate the whole team for picking up this topic and the wonderful speakers. And thank you to all our, audience and Torrent for helping us grow and, bring on new speakers and new topics. Good night and thank you, everybody.
Thank you. Good night.
All right.
Thank you.
Yeah.
Thank you. Good
Thank you
night.
all.
Good night.
Thank you all.
Thank you,
Good night.
Dr. Anup. Thank you, Dr.
Ending the
Kalpesh.
meeting.
Thank you, everyone.